This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hello, and welcome to another episode of It's Not In Your Head podcast with myself, Justine Feitelson, and of course, Dr. Dan Bates. Hey, Dan.
Morning, Jez. How are you?
Thank you.
You got your guns out
tired,
today.
but whoa.
Guns are out.
Oh! Gotta warn
There they
people.
are.
Yeah. Well, we were laughing about it because I'm in between patients today, so I did not have time to put on my INEA uniform, so the guns are out.
Guns are out.
Guns are out.
It's okay, because this is an episode that, I'm going to call it the power episode. Because I love what we're talking about today. So
power episode. All right. I'm into it. So today we're going to continue on with the theme of various procedures, tackling basivertebral nerve ablation specifically. So
Basivertebral.
Yeah.
Ablation.
What's the short? BVNA.
Yeah.
So,
okay. All right. So before we jump in, I'm going to do some disclosures.
Yeah, we got to do some asterisks.
I've got two disclosures on this one. Number one is I really like this procedure. It's currently my favorite procedure, so I'm biased towards it because I like it. The other disclosure is not a disclosure right now. So while we were recording this, I don't have any financial disclosures, but by the time it's released, I will. I've been. What they're doing with this procedure is they're registering it in Australia. I've been asked to support the company that is registering it in Australia, which is now Boston Scientific.
Okay.
So I'm just going through the process of signing some paperwork with them to then support them to get it registered. So I will have a financial disclosure. So if you want to ignore everything I say from here, go for it. But, they're not paying sheep stations, I can tell you that. All right.
Well, and the purpose of that, too, is to increase access to the procedure, basically.
Oh, yeah.
Right, Dan? So it's like, if it's helpful and effective, you're trying to broaden that.
Oh, absolutely.
Not a bad
this
thing.
is a procedure and it is a device that Australians should have access to, which we don't at the moment. And so that's essentially where I've said, yep, I'm very happy to help because this has been very good for my patients for how we do it at the moment.
How are you doing it up until that point then, Dan?
Oh, let's talk about that bit in a moment. Let's talk about what it is first.
All right,
okay,
we're
we'll
circling
talk
back.
about ticking in a minute. Okay, so
all right, deal.
Basivertebral nerve ablation is used to treat disc pain. So disc pain, when we're talking about discs, are the discs that go between the vertebra. So when everyone says, oh, my discs are gone or I've got degenerative discs, blah, blah, blah. What we are talking about is we're talking about treating that pain. Now, my experience with discogenic pain is that there is two components to discogenic pain, a deep ache and then intermittent sharp pain. Now, basivertebral nerve ablation is excellent, and by far my favorite thing for taking away the intermittent sharp pain.
That's what I thought, yeah.
It does take away the deep ache in some patients, but it's a much, much smaller group of patients. So it's more like 20% of the patients become pain-free, where the intermittent sharp ache goes away in nearly everyone. And so that is why it is my favorite procedure.
Are both types of those symptoms or each of those components coming from nerve-related stuff, even though one feels like a deep ache and the other is more of the classic sharp pain, stops you in your track? Not the surrounding.
Yeah, perfect. So you said the right thing. So it's an intermittent sharp pain that stops you in your track. So it's that pace, what we refer to it in, we use big words, it's called kinesiophobia, which is fear to move. So patients get really scared to move. And every time they go, and boom, off goes their back. And they're like, I've slipped at this. Well, no, it's not a slip.
Right.
Do that. So it's that sort of pain. And it's, you can see the patient walk through the door and they're scared to sit down. They're scared to stand up. Everything. And the thing is, it's random.
Yeah.
And the random component of it makes it really hard to get any rehab done. So someone's telling you to do your core and, do your McKenzie stuff. And then every time you try and move, you get this bang, It fires
and you
off.
can't even find a pattern on top of it. So at least you open up that window where you stop that super sharp, terrified of everything, and the deep ache you can do a bit more business with.
Exactly. And so where I'm been using this is for patients that have the intermittent sharp pain, stops them in their tracks, and it's the thing getting in the way of getting your rehab done.
Yeah.
Fantastic. This is literally my favorite procedure for this. If you want to come down to where the pain's coming from. So the pain from discs looks like it's coming dominantly from two components. Number one, the disc itself, which is essentially a big shock absorber. And when you get degenerative discs, essentially it's just like what happens if you take the shockers out of a car. Like if you take shockers out of the car, everything around the shock absorbers starts to break down. So that's what happens with discogenic pain. So the discs start to degenerate, and then the bone on either side starts to degenerate as well. And so that is it's the bone that gives you the intermittent sharp pain. So what happens there is that the nerve supply to the bone is called the basivertebral nerve. What we do is we do a basivertebral nerve ablation, so we're heating up the nerve, and that then decreases the intermittent sharp pain.
One thought I had was, so this is the same procedure that we covered in the ablation episodes, except for this is for the basal vertebral nerve rather than SIJ.
Yeah, good question.
So same procedure, different.
Yeah, okay, so there's a couple of different things. That's a really good point. So same technology in that you are heating up the nerve, different outcome, because the nerve itself is different. When you're doing a nerve ablation on facet joints or your sacroiliac joint, you're heating up a nerve that sits inside a sheath. Now, what actually happens, you coagulate the area, you don't burn it.
Okay.
It's kind of like if you happen to cook meat in a microwave, as it goes to red to brown, that's called coagulation, basically. So it's like it's cross-linking the protein fibers, and that's
now I really feel like a piece of meat.
Oh well,
that's a good example. It's good. Yeah,
everyone
good metaphor.
Know what it looks like. Anyway, so what happens there though is that because the sheath remains intact, the nerve regrows along it, and that's why you get this period of time with normal ablation that lasts for 9 to 18 months if you do a good one. Mm-hmm. With basivertebral nerve ablation, what's different is that the nerves are called proliferative nerves. So what ends up happening is when you get inflammation in an area over a period of time, you get what's called neovascularization. So you get lots of blood vessels that grow, and you also get little nerves that grow with them, which are called proliferative nerves. Now, those proliferative nerves don't have any nerve sheath. So when you cook them, they don't regrow.
Yeah. So you get better duration with this procedure.
So you get better duration. And the data on basivertebral nerve ablation is they've taken the studies out to 5 years, and people maintain their pain relief out to 5 years, and they continue to improve over that period, which is effectively
pretty unusual with procedures.
Oh, this is like an amazing. This is
like even Prolo. Yeah.
Yeah,
that's awesome. I can see why it's one of your favorites.
Yeah, that's good. Now, so the other thing that I like about it is that for the intermittent sharp pain, the onset of action is really quick. So it can be anything from, patient wakes up the next day and their pain's gone, through to it goes away in about a week. So, and it's so far been particularly reliable with how it does that. And my experience with it so far is that it is also reliable in duration. So, So let's give my little story about how I came to basivertebral nerve ablation. So
how Dan came to basal vertebral.
I first got introduced to basivertebral nerve ablations in 2014 when I was like a baby doctor doing this stuff.
Medium.
I was in for a while, but by that time, I'm really traveling all over the world at this point in time to learn different procedural things. And
so expanding the procedural bucket of stuff.
Yeah. So I went and saw a friend of mine in Colorado, and one of the things he did was a basivertebral nerve ablation. And I looked at it and I went, there is not a chance in hell I'm ever doing that thing.
Oh, I want that.
So,
How come, Dan?
Okay, so when you do this procedure, what you've got to do is you're going through bone. Okay, so you've got to go through what's called a pedicle, which is little arms that come off the back of the vertebral body, and you take a big needle that goes down through the pedicle and then into the middle of the vertebral body, and you've got to get your hammer out and
really like push it through.
So so it's not. So you've got to put on your big boy pants.
Yeah, it's not procedure. A little baby procedure,
and it's not the procedure to do when you've been doing medial branch blocks for 12 months and a couple of RFs. You've got to have a bit more experience under the belt.
Yeah,
but get another 9-10 years down the track. I've done thousands and thousands of procedures, and so I'm starting to get more.
You have the confidence and the skill level to
innovate. And by that time, the colleague that I'd seen in the US, in Colorado, Rob Wright, had joined us in Australia, and so he was with us in Australia, and he was like, "Come on, Dan, put your big boy pants on. You have to learn how to do this." And so and I had effectively a world expert to hold my hand and teach me how to do it, which
in and of itself gives you confidence.
Which has been representative of my entire learning experience. That I'm at a place, I work mainly at a place called Metro Pain Group, and I have been surrounded by world experts, and I've been an amazing learning journey that is pretty unique. So anyway, off that topic. So when we started doing basivertebral nerve ablation, the data is pretty good. So the data shows that essentially 60 to 80% of patients get greater than 50% pain relief. So that's pretty good. 20 to 30% of patients become pain-free, which is amazing. The effect lasts out to 5 years. And before I started doing this procedure, we already had the 5-year data that was published. So I'm like, okay, this thing is amazing. I can't ignore this. I have to give it a crack. And it's quite diagnosable. So at that point in time, the main study was done, and how you do is lower back pain, but the specific MRI findings, and those MRI findings are called type 1 or type 2 modic changes. And so basically what that is, it's essentially the inflammatory changes in the bone on either side of the disc that indicates that you've got abnormal loading of the bone that's taken place. And so if you put this, central lower back pain, type 1 or type 2 modic changes on scan, it's fantastic. So we're like, so at this point in time, I'm like, awesome. Yeah. We had also, because we're like, let's double check. We were doing what's called a discogram. So discography is where you put a needle into the disc, inject into the disc, and see if you can reproduce your pain. So we were doing that as well. Okay. So we're doing, so we've got, confirm it. Yeah. So we've got, patients got lower back pain. At that point in time was both the sharp and the ache stuff. Right. They got the right MRI changes, and they've got a positive discogram. And I'm doing the procedure. I've got world expert holding my hand, and they're not getting better. And I'm like, what the hell?
I don't like this.
And so I'm like, seriously, because of the nature of medicine, there's a thing called number needed to treat. So I'm like, okay.
Check out our earlier episodes on that topic.
Yeah. So which means I'm like, okay, data's good. It's a number needed to treat issue. We'll treat it. So I get through, and I'm treating a bunch, and they're not getting better. I'm like,
still,
this is killing me. And I got to the point where I was effectively about to abandon the procedure.
A little disillusioned.
Like, okay, this is all rubbish. I don't know what. Forget this. Until one of my colleagues, Guy Buchanan, says, I did a BVNA yesterday. My patient got up, all his sharp pain's gone away. I went, really?
Interesting.
Right. And I went, I had one of those earlier this week. I went, maybe it's the sharp pain.
It's the sharp pain rather than evaluating all the pain. And you still have that annoying aching. And then the patient's like, I'm a little better. Exactly. Not really.
And so I then serendipitously, it was a January. I remember this. Like I had this
January 6th on a lush afternoon.
It wasn't January 6th. It was actually late January. Anyway, so it was early January, and I had a series of patients come in that all had intermittent, like lower back pain, intermittent sharp pain, stopping in their tracks, and like absolutely just horrendous pain, destroying lives. And I went, okay, awesome. Let's have a great
BVNA for you. Yeah.
So I did a BVNA, and I then couched it in terms of, I don't think it'll take away the deep ache. I think it's going to take away the intermittent sharp.
Yeah.
And
now it all falls in.
It does. Oh my God.
Cool.
And it was fantastic. And so all of a sudden I felt like, okay, now I can start to split this up. I can now see that I've got a very clear indication, which is intermittent sharp pain that stops you in the tracks with MRI findings of
that confirm the diagnosis.
Yeah. And that pain definitely goes away. You've then got that lower group of patients, like 20 to 30% to become pain-free, and you're like, am I amazing? Interestingly, if you look at the study numbers are fascinating because, you know, you really do see that their pain comes down to, I think we started at 6, they come down to that 2 range.
Right.
And I think that 2 to 3 range, what you're seeing there is you're seeing the deep ache.
Yeah. Right.
But if you look at the study's functional data, which is called the Oswestry Disability Index,
ODI.
What they had in that was this 20 to 30 point decrease in Oswestry disability. That is an unprecedented.
Huge. That's crazy, because we've been tracking that with my back pain too. And that's a lot of it is, well, how much does it improve function, even if you're still left with some pain? And I think that's such a good example of how you preface and communicate and set patient expectations.
Yeah.
So it's not only how you are picking the patient, but the patient having a better perspective on the procedure rather than, I still have this deep ache and it's not what I want. And then you can actually improve. Yeah.
So the functional data in the study is amazing. And I think that if you look at the pain outcomes in those studies, you look at the functional outcomes in those studies, like that it matches my clinical experience. And so I'm like, okay, I think that, that study is amazing. So this procedure, so the next question you're going to ask me is, what's the risks?
That could be the next question.
Yeah. Okay, let's go with
what are the risks, Dan? Let's go. Good question.
So risks of the procedure, same as everything else. So you get a needle out. So you got infections, you've got bleeding, you've got bruising. Now, I think the bruising is quite a risk for this one because what we're doing is we're going into bone, and and you're creating a hole into the bone where you've got bone marrow, and so yes, you can get a bruise afterwards. So not common, but it certainly can take place. Risk of infection is low, but possible. An infection in a vertebral body would be a disaster. So, we're obviously exceptionally careful with that. Yeah. There's a couple of other risks. So there's bony risk to start with. So when we're doing the procedure, we're going through the pedicle. So the pedicle is essentially like it's a bony tunnel that we're running through. If you go too close to the midline, you can fracture the inside wall of that tunnel. And if that fractures, you can get a nerve root compression. Now, it is a super rare complication. It's the one that we all worry about. So it's the one we sort of talk about all the time.
We really try to mitigate.
But it's there. Fundamentally, it would mean that if that did take place, you might get a nerve root compression, which may need to be decompressed. I would think that what you're probably going to do is wait it out, see if it just calms itself down, and then, away you go. It is a small risk of a major complication. So the other risk is if used in people with osteoporosis, you do get you're heating up on the inside part of the vertebra. You actually are causing some bone damage at the same time when you're cooking the nerve.
Because the bone's weaker.
There has been some crush fractures that have been reported. Once again, a very, very rare complication. Interestingly, I have seen this used for treating the pain of crush fractures, which it does quite effectively as well. Oh. So then in that setting, you're not treating, disc degeneration. You're treating like a painful disc that's not got better.
Right.
The other risk is, I reckon I've seen once, is that the original study, what it did is it did a burn for 15 minutes. Now, 15 minutes inside a vertebral body at 80 degrees.
Isn't that long?
That is long.
Feels long. I feel like that's long.
Yeah. So, and you can imagine heating up for 15 minutes in an area, you probably heat at 80 degrees. You kind of cook a wider area. And so it's the issue that you might actually cause a nerve injury. Now, it's not common, but it's possible. We're a little bit more chicken. Well, I'm a more chicken. So we only heat up inside the vertebral body for about 4 minutes. The reasoning for that is that if you look at normal radiofrequency ablation, you get your best size of burn at about 90 seconds.
Yeah, and it doesn't just get better the longer you go.
And it does, the lesion size does get bigger. But the exponential size of it is not large. So you go from 90 seconds to 2 minutes to 3 minutes. Like, it doesn't get that much bigger.
And the increase of improvement compared to the increase in risk as you get bigger.
We do a lesion at 4 minutes. I suppose the question is, do you need to even do 4 minutes? But it's sort of like this balance between, if we're doing it in muscle, it's 90 seconds. It's very easy to heat up the space in there because it's in blood. And,
it's already in liquid.
That ends up being we think that 15 minutes is too long till we go 4. So anyway, whether we're right or not, someone will have to do a study.
That's what we do.
Now, that said, so I think I probably had one patient that may have had a small radiculitis, so like some inflammation of the nerves post-procedure. We treated that with a pulsed radiofrequency and an epidural over the nerves that we thought were affected. And then all his pain went away and it was all high fives. But it is one of the risks we need to be aware of.
It's a good list of risks.
Yeah, so post-procedure, there's no major limitations.
Recovery.
Yeah, it's like with every procedure, it's not the time to start running marathons.
Your new exercise program?
Yeah, but it is the start. It is the time to start now that you've taken away that intermittent sharp pain. It's a time to get going with your core.
Yeah.
Gradually build your strength. And hopefully it's that ability now to do your rehab that helps improve stability around the spine and then decrease the
aching and the other stuff. Yeah, because I was like, some of that comes from the instability and weakness that it results in.
Yes.
Which you got to have a window to improve. Yeah.
And the pain inhibition. So,
yes. My favorite topic.
All those things. So yeah, basivertebral nerve ablation.
It's an interesting one.
It's a good procedure. I do like it in the right patient.
Yeah, this is a great example of great procedure if you pick it and do it in the right patient. Not a great procedure if this is not the problem.
Oh yeah, but your facet joint's causing the pain. It's not going to work.
So again, this is tying all the way back into making non-specific diagnoses more specific, and then given that, matching them to the best treatment for it, which this is a good one. Thanks, Dan.
This is a good one. All right. Yeah. Thanks, Joss.
All right. Thanks a bunch. We will see you next time on another procedural episode of It's Not In Your Head podcast. Take care.
Bye.
This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.